Dear colleagues, welcome to our dialogue. You can feel that my voice today is sad. Usually my voice is more joyful, but today is sad. And the reason is what I'm sure many of you know. Jean Bradwell passed away a few days ago. He has been a father for many of us. He has been a grandfather for others. Definitely is universally recognized as the father of modern cardiology. In the last 70 years, he shaped cardiology. Personally, I am very, very grateful to him for what I have learned from Jean Bradwell. And also when I started my experience as editor-in-chief of the European Heart Journal 6 years ago, I shared my vision of the journal with him, and I received a huge amount of important suggestions. By the way, our first dialogue was with him, and also his Bradwell corner in the journal has been extremely successful. More than 20 contributions from him, single author, in the last 6 years. And these 20 contributions are the summa of his vision of cardiovascular medicine. Before starting our dialogue, I propose a minute of silence. And now let's come to our dialogue, to our monthly Socratic conversation. Today we have a famous, wonderful guest. I'm sure will be a very interesting and enjoyable conversation. His name, you know him very well, all of you, is Steve Nissen. His contribution to the history of cardiology has been and is remarkable. And I've also the pleasure to introduce Peter Libby, Executive Editor of the European Heart Journal. And we will host together Steve Nissen for this remarkable hour in front of us. I'd like to, by the way, I remind you that all what our dialogue is streamlined in X and will be posted also in YouTube. So if for some reason you cannot finish today for the dialogue, you can find the dialogue in YouTube. But let's come back to Steve Nissen and Peter Libby. It's my great pleasure now to ask Peter, perhaps starting with some comments on Peter Libby, and then Steve also from your side. And Peter, the floor now is yours with your as we say in Italian, ricordo of Jim Brown, and then you will introduce Steve Nissen.
Yeah. So you asked me to speak about Jean some. So this is a adventure with the conjunction of the U.S., represented by me and Steve, and Jean, who is an immigrant. And I think that there are a couple of lessons that I'd like to point out. The first of all is how immigrants like Jean, who fled the Nazis from Vienna in 1938, how they enriched the United States. And we should never forget the value of immigration and what they've contributed to the American society. And during the moment of silence, I was contemplating not only the loss of Jean, but the loss of all the people who grew up around him in Vienna and other places who didn't make it out, and what they could have contributed to society as he did. So, Steve, maybe you have a reflection about Gene, and then we can delve into some of the things that we'd like to speak to you about.
Well, what was remarkable about Gene Burnwald is not just his contributions, but all the people he mentored and trained. It's just, several generations of greatness in cardiology that stemmed from his leadership and his willingness to always help people learn, get better, publish, write. And he did that for me. He was very, very supportive early on. When I was beginning to work in the area of intravascular ultrasound, he got it, he understood it, and he advised and counseled me about the direction that I was going in. And his generosity with imparting his skills and knowledge to so many other people is a remarkable achievement that took place over many, many decades. And I don't know that there'll ever be anybody like Gene Burnwald again. He was a unique individual whose contributions we cannot possibly overestimate.
So Steve, how did you catch the cardiology bug? What got you interested?
Well, it was really interesting. As I was at the University of California, Davis, Dean Mason was there, who some of you know, and his kind of understudy was Tony DeMaria. And I went into the coronary care unit where Tony was the attending. And many people don't know this because they know Tony as an echocardiographer. But in fact, he was actually worked in the cath lab as well and in the CCU. And it didn't take me long working with him in the CCU to know how dynamic cardiology could be. And like many of us, I think, on this video, we had somebody who inspired us. And I found Tony to be inspiring, quite brilliant, great teacher, and I wanted to emulate him. And so I decided to go into cardiology.
Yeah. Oh, that's a great story. And of course, Dean Mason was one of Gene's acolytes.
I know that, yes.
LBI, right. So you just told us that Tony DeMaria was your role model, and we all have rough patches in our career. I've known you for a long time, but I've never seen you in a rough patch. But I'm sure that there were some moments of difficulty. Anything you care to share with our audience?
I think the most difficult thing that I ever did was twice in my career, I was involved in a drug safety controversy. The first one was with regard to rofecoxib, which, I became very concerned about increased cardiovascular events with that drug after serving on an FDA panel. And I realized that there really was an underappreciation of the potential adverse effects of COX inhibitors on cardiovascular outcomes. And so, together with colleagues here at the Cleveland Clinic, we published a manuscript in JAMA, and we raised the question about the safety of rofecoxib. And it put a target on my back. And I had to live through a great deal of animosity, from the maker of that drug. Some of you may know about this, but letters were sent around the country to leading cardiologists with the claim that I was being paid off by their competition to write negative things about rofecoxib, and had to weather that storm for 4 years until the drug was actually proven to be harmful and taken off the market. But that was hard. And if that weren't bad enough, about 6 or 7 years later, I did it again. And this time, I was concerned about rosiglitazone. At the time, you could get a drug approved for diabetes if you just showed that it lowered blood sugar. You didn't have to show any other outcomes except for that one biochemical measure. And I became very concerned in reading the literature that every one of the studies that I came across, there were more cardiovascular events with rofecoxib than there were with the control agents. And so I went searching to try to to understand this better. And as serendipity would have it, there had been a lawsuit against the maker of that drug.
Rosiglitazone is what we're talking about.
Yes, rosiglitazone. Yeah, rosiglitazone. And for rosiglitazone, that lawsuit had was from the Attorney General of New York State, and who was concerned about negative publication bias related to other drugs. And there was a settlement for the rosiglitazone maker that they would have to post on a website all of the data regarding all of their outcome trials. And I found that website, downloaded all the data on rosiglitazone, and my statistician and I, Kathy Wolski, analyzed the data, and we saw an increased risk of myocardial infarction and cardiovascular death. And we submitted a manuscript to the New England Journal of Medicine that was published actually 21 days after we submitted it. And that controversy was even bigger with regard to rosiglitazone. And again, there were congressional hearings. There was a lot of animosity. You know, you just have to realize that it takes some really, tough times if you want to take on an issue like that. But again, weathered the storm, and ultimately it led to something which I think was pretty important, which was a change in the way that diabetes drugs are regulated. So the following year, FDA had some hearings, and I went and was asked to testify at their hearings about what to do about this controversy related to diabetes drugs. And I made a proposal, and the proposal was to require cardiovascular outcome trials for new diabetes drugs in a two-stage process that's now well known, where you had to first rule out a hazard of 1.8, and then you could rule out, after approval, a hazard of 1.3. There were two other speakers that followed me. One was Rob Califf, and the other was Rory Holman. And they both supported my proposal. I was very grateful to them. And surprisingly, the FDA advisory panel, consisting mostly of endocrinologists, agreed that outcome trials would be required for diabetes drugs.
But a lot of people, Steve, were saying that you were going to kill the field, that people wouldn't develop any more diabetes drugs. So we know what actually happened is that we learned that some of these agents have incredible cardiovascular benefits that we wouldn't have known if you hadn't been the agent of change. So how does that feel?
Well, I don't think there's anything I will ever do in my career that is more important, because it really needed to be done. Approving drugs based upon their biochemical effects rather than their effects on the things that patients care about was never a good idea. But that was the tradition, and it had to be, something had to be done. But yes, it does feel good now. But at the time, it was very, very difficult. When I went and looked at the slides that I showed to the FDA, the final couple of slides, what I said was, if we require safety trials for diabetes drugs, we are going to find drugs not only that are safe, but maybe that are going to produce benefits. And the first of the trials didn't show any benefits. The DPP-4 inhibitors that were widely hyped showed no benefits. There were, a bunch of trials that just showed neutrality. But then one day, I got a visit from some people from Germany, from a company born near Engelheim. And they revealed to me that they had just unblinded a trial of their SGLT2 inhibitor and empagliflozin. And they showed me the mortality data from empagliflozin, and I was, amazed. And as I think everybody on this call knows, we learned subsequently not only did SGLT2 inhibitors reduce cardiovascular events, but they improved heart failure, they improved renal disease, and then along came the GLP-1 agonists, and each of those drugs had to do an outcome trial. And the outcome trials didn't show that they were neutral, that they lacked harm. They showed that they were beneficial. And so I think what happened was we were able to move the needle. I had to take a lot of heat. I can tell you that when I testified in Congress, the more conservative elements at that congressional hearing, I was severely attacked. Lots of people said this was a terrible idea. And then, in fact, there would be no new diabetes drugs, that no companies would ever invest in doing a large outcome trial for a diabetes drug. But they did. And the results, I think, have been something that I'm very proud of.
So, Filippo, you should weigh in here.
Yes, with pleasure. Well, Steve, you have many talents, and in particular, you devoted considerable efforts in addressing public health related issues, a very important topic. Can you tell in particular about the sport study, including supplements? A fascinating story.
Yeah, it's another interesting story. The I know there are different approaches in Europe and in the US, but in the US, you can go into a drugstore and there are just rows and rows and rows of dietary supplements. And they make a lot of claims. They can make your brain work better, they can help your heart, etc. And we have patients coming in, we want to treat them with statins. And Peter, you and I should maybe talk a little bit about our early work together on the statin area. But I have patients that say, I don't want to take a statin. I can just take turmeric and I can get all the benefits I can get from a statin. And so on a shoestring budget, we got a little bit of a grant from one of the pharma companies, and we did a trial where we studied 6 dietary supplements, and we compared them to placebo and rosuvastatin. And what we found, of course, was that the dietary supplements didn't do anything. They didn't change LDL cholesterol. They didn't change C-reactive protein. They didn't do anything. And in fact, one of them, garlic, which was widely being promoted, actually raised LDL cholesterol. And so, we published it. And, I've heard from many colleagues around the country that when patients come into their clinic with this list of 15 dietary supplements they're taking, they hand them the article and they say, look, these dietary supplements don't do anything. You need something that's actually going to work, for your cholesterol. And hopefully we've helped some patients with that. But that was an interesting project. And my young colleague, Dr. Luke Laffin, led that study. And he's, by the way, a really talented young guy. And again, I've really been enjoying in the latter part of my career being able to mentor people of that level of talent.
Well, this is extremely interesting, considering that now in Italy, for instance, when I visit patients, many of them tell me, but why should I take a statin, which is dangerous because can provoke pain in the muscle, and while we can have this other thing which is natural and reduces cholesterol, why should we go for a drug? And then patiently explain them the reasons why we have to go for drugs and not for supplements. But it's not an easy game. Also considering that now supplements are more expensive than drugs, more expensive than statins. But I think that really here internet is not helping, because patients go on internet, Google Doctor Google, and then they come up with this fancy observations. So perhaps, Steve, you should republish, if you want, also in the European Journal, these all studies should be reproposed. Or if you want to write a viewpoint on this important issue, you are really very, very welcome.
Well, I would like to. I wrote in the Annals of Internal Medicine, I wrote an article entitled "Statin Denial: An Internet Cult with Dangerous Consequences." And boy, did I get hate mail from the dietary supplement industry. I have a picture that they have of me with a dunce cap on my head. They were very, very aggressive. But the reality is that we've got to tell people this. And the internet is both a blessing and a curse.
Yeah.
And there's so much fake news there. And it happens now in politics and it happens in medicine. And I'd like to do the study again. There are a lot of dietary supplements that claim to be able to lower blood pressure, like beets. That's been widely advertised now in the United States. And I'd like to study it because I don't think it probably works, but we can certainly find out.
Well, this is an official invitation for a viewpoint in the European Journal. We also pay for the bodyguard, so don't worry. I mean,
I didn't need one.
we will protect you. Now, what about the health system in Europe and US? What can we learn from each other?
Well, I've been very critical of the health system in the US. We spend twice as much per capita as most European countries, in some cases more than that, but we're not healthier. And the question is, what are we doing wrong? And I think the biggest problem that I see in America is the disparities in health. If you're wealthy in America, you get the best health care in the world. But if you're not, you get relatively poor health care. And so the unevenness of the healthcare system is what drags us down. And our infant mortality rates are higher, and our life expectancy is shorter than many European countries. And we spend so much more money. And I think what we've got to really do is, I have been a believer for a long, long time in a single payer system. I believe that everybody deserves health care, that everybody should have health care, at least basic health care. It should be part of being a citizen of our country. We're a wealthy country. We can afford to do this. For the cost of one or two aircraft carriers, you could take care of an awful lot of people's health. And I think we've got misplaced priorities.
Thank you, Steve. Very important considerations. Perhaps we can come back to this later. But now back to Peter. Peter, please.
Yeah, so Steve, you really were a pioneer in intravascular imaging with your IVUS. You did pivotal studies. You were the first to actually show one could regress atherosclerosis using intravascular imaging. And of course, that was the prelude to optical coherence tomography, OCT, and the NIRS, the near-infrared spectroscopy as intravascular techniques. But the CT has made leaps and bounds. The photon counting CT, with the spectral information which we lose from conventional CT, is going to be, I think, a huge way to characterize plaques non-invasively. I predict that in the next 5 years, the literature is going to be burgeoning with using photon counting CT to characterize plaques. And also, as you know, I've been interested in the peri-arterial fat.
Absolutely.
Fat attenuation index. And I wonder, as a pioneer and advocate and successful practitioner of intravascular imaging, what do you think about non-invasive imaging? Do you buy into some of the enthusiasm that we have about computer tomography and maybe things like the fat attenuation index?
Well, I am very enthusiastic about them, but I think we've got to we got to work very carefully. So what happened with me is, in 1985, a small company came to visit us when I was in Lexington, Kentucky, with Tony DeMaria. They knew Tony from his ultrasound work. And they said, we think we can put an ultrasound transducer on the tip of a catheter and make images of the interior of coronary arteries. And I was given the opportunity to begin leading the research in that area. And over the next 5 years, we were successful eventually in building catheters that we could use. You and I were very much involved. You were one of the people that helped me. One of the first trial we did that actually showed unequivocal regression was the asteroid study published in JAMA. You were a co-author. You will certainly recall that was a long time ago, but it was very important. And that was more than 20 years ago. But we were able to show that if you could get LDL cholesterol down low enough, you could regress disease. But the era of invasive imaging, I think, we're moving away from it. Your points are well taken. CCTA has made great progress, but I want to give a word of caution in two areas. One is, before we ever did those first studies with IVUS, we built a core laboratory where we understood the variability, how to control standard deviations, how to do this precisely, not in a single center, but in a multi-center trial. And that has not happened as quickly as I would like with CCTA. We need better multi-center studies. We need better core laboratories. We've got one where, here, but there are some others. And there's been a lot of confusion. One of the areas of confusion is the use of AI interpretation of CCTA. And I've yet to be convinced that AI interpretation is actually a good thing. And I'm worried about whether we've done our homework. And so I think for the volumetric measurements by CCTA, we need better quality studies, better validated. Now, fat attenuation index is very interesting because you and I both have been advocates of what used to be called the inflammatory hypothesis, but I think it's the inflammatory mechanism of atherosclerotic vascular disease, and the ability to measure that non-invasively, with CCTA is a potential breakthrough, but we're going to need careful studies, well-controlled, with results that are able to be reproduced by others. And we're just getting there. And I think the next 5 years will be an explosion of the use of non-invasive imaging to develop drugs, to improve, to refine treatments, set new targets. There's lots of opportunity here to develop things, including things like NLRP3 inhibitors, which I know is something you're probably very interested in as well.
Yeah, so thanks, Steve. Our role model for many of us on the panel and online is Gene Brommel, who was unflaggingly pursuing new questions well into his 90s. And we're sort of the same. I know that you're involved in a whole bunch of new studies. You have some ongoing studies, which I'm looking really forward to the results of Horizon. And you're engaged in other novel studies. Maybe you can bring us up to date on what's in the pipeline. And I'll tell you something that I probably shouldn't, is that when we learn that pelacarsen is safe and effective in people who've had an MI, I have patients in my panel who I'll discuss with them in a shared decision-making manner, them and even their offspring who are affected by high Lp(a), using pelacarsen and other agents as they prove safe and effective off-label in primary prevention, because I think that I have a whole stable, as you do, of patients with high Lp(a) who are really victims of premature disease.
Well, it's certainly an important target, and We've worked very hard on this. The LPA Horizon trial is one that I worked on the design of beginning in 2019. We've announced that the trial will conclude in the second half of this year, and that will be an important trial. There are other drugs in the class that we're working on. I'm the study chair for the ACCLAIM trial, which is studying a small interfering RNA called lepodisiran. It's a 17,300 patient trial. And for muvalaplin, which is a very interesting drug, which disrupts the linkage of the ApoA component in lipoprotein A to the ApoB component to prevent assembly of lipoprotein A particles. The other area of interest has been obesity. And we have a fully enrolled 15,000 patient trial with tirzepatide that's placebo-controlled in people with obesity but without diabetes, and both in primary and in secondary prevention. And we're going to see if whether this very powerful dual incretin that produces typically 22% or so weight loss, whether it can reduce morbidity and mortality in patients without diabetes, with obesity in both primary and secondary prevention. So those are the ones that are getting the most attention. And then more recently, we've been involved in gene editing. And we published last year our first study showing that we could edit the ANGPTL3 gene, knock out the gene, and we lowered triglycerides and LDL cholesterol simultaneously by up to 50% permanently with a single treatment. And we have multiple other gene editing programs that we're doing, along with multiple other small interfering RNA programs, including small interfering RNA programs that involve targeting two messenger RNAs from a single drug. Think of it as two linked together small interfering RNAs that can actually treat two hepatic targets simultaneously. So, that's one of the things I always knew about Gene Grunwald, is he went from working on, rat papillary muscles with digoxin to thrombolytics to everything else. And he was constantly looking at new possibilities. And I think, I would certainly like to be able to follow that kind of course and pursue whatever scientific objectives make sense to try to bring benefit to patients.
Steve, I have some additional questions. One is about risk factors. We've been sitting comfortably on Framingham risk factors for more than 50 years, but a bit more than 1 year ago, Christina Magnussen published a very interesting global study in the New England showing that these traditional cardiovascular risk factors explains only 50% of 50-60% of cardiovascular risk. The rest is probably related to inflammation, to the exposome, infections, and so forth. Do you think that we should really reconsider our approach to risk factors based on this data?
I do think we should. And, we are beginning down this pathway. I mean, as the sequencing costs have gotten down, I'm told by Krishna Aragam, who I think, Peter, you know very well.
He started out as a Harvard undergraduate in my lab.
Okay, so you know him particularly well. He's one of the many people, by the way, Peter, you have mentored over the years. But he tells me now that you can sequence for about $100 to $125. And so we are now proposing that in all of our outcome trials that we do genome sequencing, and we want to find more new targets. And the best way to do that is to have very, very well phenotyped people and study them prospectively in these clinical trials. And I think what we're going to find is that one size does not fit all. That for some people, targeting inflammation will be the most important target. For others, targeting lipoprotein A will be the right approach. And for others, it'll be maybe triglycerides even, and remnant cholesterol. And so my hope would be that our sophistication about understanding the drivers of coronary disease can get better if we do the right trials. And I think, now there's beginning to be a realization by, industry that you can't develop a drug that will work for everybody. And frankly, it's not efficient and it's not cost effective. And so I think we're going to find that we can find a better way to target the right therapy for the right patients. And I know, Peter, you're involved with a number of anti-inflammatory approaches. I don't know which one's going to turn out to be best, but hopefully maybe gene sequencing can help us figure that out.
Yeah. Well, that's why we do the trials and have to do the trials.
Yeah. Yeah. I hope we'll continue to do the trials. I'm a little bit concerned that now one of the things that's happened in America is the FDA is somebody's blown up the FDA, and they have kind of opened up their approach. They're now at least considering, and maybe hopefully won't go in this direction, about allowing what they call real world data. It's not a term I use. Real world evidence is the term. And I don't think there is such a thing. I think it's real world data. I think evidence comes from well-controlled clinical trials, not from real world data. And I don't want to see the randomized controlled trial go away in favor of less rigorous evidence. But right now, that's where we're headed. And, it's already resulted in some pretty strange recommendations. I know many Europeans are not aware of this, but, we've got dietary recommendations telling our population to cook with lard, rather than olive oil. And I'm not Italian, but the only kind of oil that's in my kitchen is olive oil. And I eat the Mediterranean diet because it's a healthy diet, and I don't cook with lard. Thank you, RFK.
Well, also coffee is good for your health. We recently published a study confirming that coffee is good, in particular if drunk in the morning. So in addition to the olive oil, don't forget coffee.
Yeah. Filippo, I get to work at about 4:30 in the morning every morning, and by 6 o'clock, I've had 6 cups of coffee. So you made me very happy with that publication.
Yeah, it's well cited and well downloaded. But let's come to risk factor and non-traditional risk factor. It is clearly emerging that the burden of infectious diseases is important. Starting with oral hygiene, there is a nice study published again in the European Journal by John Dinfield. He randomized patients with periodontitis to standard care versus excellent care, and this resulted in an improvement of carotid atherosclerosis. So the issue is there. And recently we published an official document of the European Society of Cardiology with a provocative title, which is Vaccination, a New Form of Cardiovascular Prevention. I think that vaccinations are really underutilized. In Europe as in US, what are your feelings? Is a new form of cardiovascular prevention? Do you agree?
I think you're absolutely correct. And, I was really quite impressed by some of the data that's now come out about the shingles vaccine, the herpes zoster vaccine being cardioprotective. And but we have a problem, and that is we have this terrible anti-vaccine movement in the United States that's gained a foothold. And it is making me very sad that we have now children dying of measles again in America. And I'm worried about polio coming back. And so vaccines are probably, from the point of view of safety and efficacy, there's no better bargain in all of medicine than vaccination. I mean, if you think about all the lives saved and how few people have any serious, complications from vaccines, but you can't believe how much anti-vaccine aggressiveness there is now in the United States amongst some circles, including some pretty prominent political circles. So it's a real problem.
Well, okay, this is why your viewpoint is important, to show that statins and vaccines are better than supplements. This seems obvious, but I mean, obvious things now are under discussion.
Yeah.
Now, let me come back to risk stratification. I fully agree with you that, for instance, imaging of perivascular fat inflammation is extremely important. Makes sense because we are closer to the scene of crime, and the scene of crime is there. So perivascular fat is closer than blood cholesterol or even hypertension. So might be a step forward. And what you see with imaging, actually, I remember your expression long ago when you presented some data on IBUS showing how atherosclerosis regresses after statins. And you told us, well, this is not a surrogate of atherosclerosis, it is atherosclerosis. So to get closer to the scene of crime, I think is better. On the other hand, as you say, we need the rigorous validation, but it is expensive, and bioimaging is probably will be anyway more expensive than biomarkers. How do you think we can find the right balance between bioimaging and biomarkers?
Well, I think it's not going to be one size fits all. I think it will depend on, I think when we're developing drugs, I like the idea of using the imaging for proof of concept studies. So you have a new target. I know there are people working, for example, on inhibitors for TMAO, which is an interesting, marker that Stan Hazen's done a lot of work with. And, I know Stan very, very well. And
He's one of my editors.
I know he is, and he's a very, very bright guy, and there are people working on inhibitors, and it may be that looking at something like perivascular fat attenuation index would be a good way to determine whether a drug that's been developed has a likelihood of succeeding in a large outcome trial. And so I like the idea of the more expensive and more difficult techniques being used in these proof of concept studies. But for the general population, it's underutilized in the United States, unfortunately, but C-reactive protein still is a very cost-effective and very helpful biomarker from my perspective. I mean, I use it all the time, but not everybody does. And I wished it was used more often because I do think it's inexpensive. It has got good predictive value and it really deserves to be considered more carefully. The other thing about, however, imaging is that not used as much in Europe, interestingly enough, but coronary artery calcium scoring is pretty inexpensive, and it's a very, very low dose of radiation. I was a bit slow to adopt it, in part because of another problem. I started seeing patients that would come in to me, and they would say that they went to see their cardiologist, and he said, "Let's get a coronary calcium score." And they would then come in after the coronary calcium score, and their cardiologist would say, "Well, I got good news for you, and I got bad news." The bad news is that you've got a high coronary calcium score. The good news is I can do your cath tomorrow. and they've never had a symptom. And we were seeing all kinds of patients having cardiac catheterization simply because they had a high calcium score. And I was horrified by that. They needed preventive care, but they didn't need an invasive procedure. And a lot of them ultimately ended up getting, a PCI. And so I think coronary calcium scoring is great if it's not misused. And so if you're willing to say, I'm not going to let it, I don't care how high the calcium score is, I'm not going to use it as a trigger to do an unnecessary cardiac catheterization, then I think it's a pretty good technique. And I don't know, is it increasing in use in Europe, Filippo?
Yeah, yes, the use is increasing also because now supported by guidelines.
Yeah.
Well, an alternative is IMT, in carotid arteries, which is radiation-free, is another interesting way to improve risk stratification.
Yes.
Steve, back to incretins. They are really fascinating. Recently, in this obscure journal called European Journal, we published an interesting study, was a Mendelian randomization and mediation analysis, showing that only 60-70% of benefit is explained by reduction of blood glucose and reduction of weight. 30-40% still remains unexplained and probably has to do with inflammation. We know that CRP goes down. So what is your perspective for this fascinating class of drugs in the future?
Yeah, so I've been a bit careful about this issue, and let me see if I can articulate why that is. When you lose intra-abdominal fat, there are a whole family of cytokines that are reduced, some of which, of course, raise C-reactive protein. One of the first things we see with weight loss is a reduction in C-reactive protein. And there may be other mediators that are being affected. And so, well, you can say, well, the weight loss doesn't explain all of it. Well, the weight loss can be, if you will, a leading indicator of a lot of other things going on behind the scenes. Blood pressure goes down a bit. We're actually doing a blood pressure study. My colleague, Dr. Laffin, is doing a blood pressure study with the oral GLP-1 or orforglipron. So we see all of that. So it's, yes, glucose. It's body weight. It's changes in cytokines. And, there are people who would like us to believe that there is some magical kind of pleiotropic effect of the incretins. And I'm willing to believe it, but I'm going to require better proof. And so I've been a bit skeptical about that because I think that there are so many things involved in that cascade when you lose weight that we don't really understand all of them yet. And hopefully we will be able to figure that out.
Steve, I see many guests in our audience, important guests. One of them is Jan Piek, who usually is with us with our dialogues. Jan, we have another famous guest today. Any question for Steve? Amelia, please unmute. You are still muted. Can we unmute Jan?
I've tried to unmute Jan.
Okay.
Maybe you can put a question in the chat.
Yeah, you can write in the chat in the meantime, because we don't manage to unmute you. Now, yes, now you can speak. Now we can hear your voice.
Okay. Well, I was a little bit intrigued by your remark on the use of calcium score, because that is, I think, a quite, let's say, relevant topic in view of its use. So Filippo was already indicating that there is an increase of calcium score. So my question to you is, would it be, let's see, for you, based upon risk factors, the first additional examination that you would like to do in order to have it in primary prevention. So if you compare, for example, you say, I have a good argument for CRP, but you can also say, what would be the next step? Do you think there will be an important role of the calcium score in primary prevention?
Yes, I do. I think that's where I use it. There is a cautionary that I actually see people misunderstand commonly. And that is, if you've been on a statin, you really shouldn't check the calcium score. Because we have shown and others have shown that when you treat patients with a statin, the calcium score goes up because you're converting soft plaque into calcified plaque. And so if someone's never been treated with a statin and you're trying to decide, should I start a statin or should I not start a statin? CRP is very helpful. If the CRP comes back 3, that's going to push me, because of the Jupiter trial, which again, Peter knows much better than I do, was very, I think, impressive in showing how people with a high CRP, even without a very high LDL cholesterol, benefited dramatically from statin use. But I also think that a calcium score can be useful as well. And, depending on the level of concern and the level of risk, I think it can be used. It's not expensive. It's a very small amount of radiation. And, if used selectively and if people don't overreact to it, I think it can be very useful. And what we've certainly seen is I see a lot of patients that the first thing that they have had done is a calcium score. It's very high, and then they get all the other biomarkers. And sure enough, they've got a lipoprotein A of 300 nanomoles per liter. Well, probably the LPA test should have come before the calcium score, because you wouldn't have needed the calcium score to know that you ought to treat the patient. So the sequencing of what you'd get in what order should be important. And I'm still troubled by the underappreciation of the importance of having everybody get an Lp(a) at least once in their lifetime. And I was really cheered by the fact that the latest lipid guidelines in the United States now recommend that everybody get a lipoprotein A sometime in their lifetime. And I think it's the right thing to do. It's not terribly expensive. And knowing that you have that risk factor is a really important guide to getting the people who need other treatments treated. Although we can't yet lower their lipoprotein A, we may soon be able to do that, with an approved drug. We can certainly lower their LDL and their blood pressure and improve their diabetes and get them on an exercise program and treat their obesity and hold off the disease for a while.
Okay, thank you.
And cascade screening. We have to have a conversation with the patient about screening their kids and talking to their siblings.
Absolutely. Really, really important.
So strongly genetically.
I got to tell you an experience that I have that's very disturbing. I have a clinic every Friday that's mostly patients with high LPA coming from a variety of places around the country, around the world. And I get a story at least once a week when somebody says that they heard about lipoprotein A and they went to their primary care doctor and they asked to have it drawn. And their primary care doctor refused and said, there's nothing you can do about it. I'm not gonna order it. So they then you can go to a laboratory in the United States and have it done without a prescription or a doctor's order. And they find out that they have a sky high value. And their physician had refused to obtain the test. That's very disturbing.
Thank you, Steve. I see another important guest in the audience, Albert Bigman. Any question for our guest? Welcome.
Yeah, a pediatric cardiologist, so I'm really interested in all the developments for adults, and then of course we have to wait for a couple of years. but we were successful for implementing in the EU Safe Heart Plan to have Lp(a) checked in every European. So hopefully it will be done. My question, you are so much involved in many trials for Lp(a) lowering, but most of them are for secondary prevention. Are there trials to come, as Peter already mentioned, many young people knowing the results in their parents and grandparents want to have drugs for primary prevention?
Yeah, the ACCLAIM trial with lepodisiran is a 17,300 patient trial, now fully enrolled, that contains approximately equal numbers of primary and secondary prevention patients. And the same is true for the study called MOVE-LPA with muvalaplin. Amgen is now going to be running a study with olpasiran, which is another small interfering RNA in primary prevention. And so I think everybody's getting the idea. And frankly, it's so sensible. I mean, better to prevent a disease than to treat it after it's manifest. And we've got lots of evidence for other therapies that if you get to people earlier, you will have a better effect. And so I'm with the pediatric cardiologists. I want to treat younger people, and I'm very pleased that our pediatric colleagues are beginning to treat children with hyperlipidemia more commonly. Certainly in early adolescence. And I think that's the right thing to do. And it's the lifelong exposure to LDL cholesterol that's one of the greatest predictors of whether you're going to get a coronary event. And I think you treat earlier, you may not even need to treat as intensively if you start treatment earlier, because your lifelong time average value will be much lower.
Thank you.
Steve, you have been a successful president of the American College of Cardiology. Which lesson have you learned from this experience? And being president today, what else would you make?
Well, I, as usual, created some controversy when I was president, and my address, as my presidential address, was on why we need a single payer system in the United States. And not everybody in America in the private practice of cardiology likes the idea of a single payer system, but I do want these professional organizations. I'm going to say something I probably shouldn't say, but I do this anyway. Several organizations, not the American College of Cardiology, but some other professional organizations, when the Trump administration began attacking diversity, equity, and inclusion, they scrubbed DEI off of their websites. They stopped talking about diversity, equity, and inclusion. And I am very troubled by that. We need to be proactive about these issues, about societal issues, about why is diversity good? Why is equity good? And why is inclusiveness good? And we can't be intimidated into not talking about these things. So I want the leaders of our professional organizations to talk about why these are important concepts.
Very wise words. Thank you, Steve. Peter, last question for Steve.
Well, I think this is wonderful, but we have a tradition in these dialogues, and that is to ask you, who should we get for future dialogues? Do you have any suggestions?
How can we improve?
Well, first of all, by the way, I'm terribly honored that you allowed me this opportunity to talk about some of the things I've done in my career. And there are so many worthy people out there. I'd have to go back and look at the 40 people you've already had, which I'm happy to do. If somebody sends me a list, I'll send you back my own list of people. I think there may be some really interesting younger up-and-comers that are ready to kind of do this with you that could probably provide some really interesting insights. So I'd love to be able to make those suggestions.
Well, Thank you, Steve. We had a wonderful hour, very, very instructive for all of us, and very important in particular for younger colleagues. So I wish to thank you for dedicating time to dialogue and to our journal. Thank you, Peter, for this enjoyable conversation. And by the way, Steve, when we started our experience with the journal, and I thought of this monthly webinar to improve the contact between the journal and the readers and the colleagues. The question was which name to give to this initiative. And then was Peter coming up with a dialogue. And that was a very, Peter is one of the brightest person I know, and what he says is always relevant. So this is why we selected dialogues, and I think that has been a successful term, but also philosophically, Socrates strongly believed that dialogue is the way to reach the truth. And today, I think that our dialogue allowed us to reach some important truths. Thank you, Steve, again. Thank you, Peter. Next dialogue will be as usual, last Thursday of the month, 28th of May. And we come back to Europe, we will be with Andreas Zeyer.
Oh, yeah, great choice.
Thank you very much.
Thank you.
Bye-bye.